A very good evening and a warm welcome to one and all present here. I am Debolina from Clinic. We are very much proud to be a part of this Ica webinar as a digital partner. As you all know, Clinic is India's largest live digital CME and doctors-generated medical content platform. So now, without further delay, I would like to welcome Dr. Muralidhar Kanchi. Sir is a professor and senior consultant of Anesthesia and Critical Care Department. Sir is also principal of Narayana Rudralaya Institute of Allied Health Sciences. Now, I would request sir to please take over from here to start with our today's scientific program. Over to you, sir.
Thank you, Debolina. My dear colleagues, friends, ladies and gentlemen, it's an absolute pleasure for me to invite you for the second module of mechanical ventilation. We have done the first module about 4 weeks ago, and I would like to express my happiness at seeing our CEOs, Dr. Jayashree, Sood and Baljit. I'm sure Dr. Radhakrishnan and Sanish will be joining us. To give a brief introduction about the ICA webinars, we have been conducting this since last close to 2 years, and this is 102nd webinar under ICA, which has become very popular and has become a hallmark of the Indian College of Anesthesiologists. In fact, we'll be celebrating our second anniversary of webinars on the 13th of July, where all the presidents of American Society of Anesthesiologists, Indian Society, and all the state presidents will be participating. Please join us. And with this few words, I would like to introduce my panelists and moderators. First of all, I would like to introduce Dr. Ratan Gupta, who is the consultant intensivist, extensively experienced in cardiac field, works with us in Narayana Rudayalaya. Then we have Dr. Justin, a consultant intensivist at Manipal Hospital, Jayanagar, very bright and brilliant upcoming intensivist. It's always a pleasure to see him talking. Next, I would like to introduce Dr. Somnath, who's the medical director, HOD Anesthesia Critical Care at the Prakriti Hospital in Bangalore, another bright individual. And Dr. Sudesh Rao from AJ Hospital and Research Center, Bangalore, close friend and again a brilliant intensivist. So with this, I would like to hand over the stage to Dr. Ratan Gupta and Justin to conduct the proceedings. And each of the talk is for about 15 to 18 minutes. And the discussion is at the end, and feel free to post your questions and comments in the chat box. We'll try to address all of the questions at the end of the session. And I request all the participants, except the speaker and the moderator, to keep the mics off. Thank you so much, Dr. Ratan Gupta and Dr. Justin, please.
Good evening. Am I audible, sir?
Yes, we can hear you.
Yeah. Thank you, Murali, sir. Thank you, Indian College of Anesthesia, for another opportunity to be participating in the mechanical ventilation module 2. I would like to invite Dr. Jinay Gala for driving the concept of driving pressure, and he'll make us understand how to protect the lung by limiting the driving pressure. So I invite Dr. Jinay Gala. Dr. Jinay Gala, if you can share your slides, please.
Sir, is it okay?
Is a consultant intensivist at Mazumdar Shah Center, Narayana Health City. He's a young and very enterprising, and we're looking for a bright session and hope he drives the concept of driving pressure to everyone. Dr. Jinay Gala, you can go ahead.
Thank you, sir, for the opportunity. Today we'll be talking about the driving pressures during mechanical ventilation. The basic tenets of management of ARDS have always been a low tidal volume ventilation and a positive end expiratory pressures. But in spite of that, there was a lot of mortality happening. So over the years, what has been found that the concept of baby lung came into the picture after years of research. The basic problem with ARDS, it is not an homogeneous entity. It's an heterogeneous entity where few areas are more affected than the other areas. So during mechanical ventilation, the idea is now to protect this baby lung from overextension and barotrauma. When we give a certain tidal volume, definitely the PEEP that we give to open up the marginal zones in this lung tends to affect the baby lung a little more with barotrauma. That's why a few more concepts that we have to understand is the stress and the strain. Stress is defined as the force divided by the area over which it is applied. Basically, it is the amount of pressures that we are giving to the baby lung. And strain is the change in the dimensions of a structure from its original dimensions. In terms of our lung, we basically want to measure the change in the lung volume divided by the initial volume. So what we get is the tidal volume divided by the functional residual volume over here. So what is driving pressure? What do we mean by driving pressure? Driving pressure basically means plateau pressures minus the PEEP is basically the driving pressure. It is the pressure that you need to keep the lung open and closed. Now, plateau pressure is, how do we measure our plateau pressures? Plateau pressures are measured at the end of the inspiratory process during a volume controlled constant flow ventilation, or at the end of inspiration during the pressure controlled ventilation. So as we can see here, this is a pressure time flow that we are seeing, that at the after inspiration, this thing during a pause, what we see is the flow, the pressure equalizing between the alveoli and the proximal pressures, proximal airways. That's why we see a dip when we put up inspiratory pause. What the pressure we get is the P plateau, and over the time during expiration, the flows gradually come down. The pressures comes down to the P this thing. So the difference between the P plateau and the P gives us the idea of the delta P. Now comes the idea of driving pressures as this thing between the FRC and the tidal volume. It is the change in the volume that we are getting during the inspiration and expiration over here. So the delta L by the delta O, that is the FRC that we are giving, the volume over here, which is left, and the change in the change in the volume that we are giving is the pressure, that the strain that we are putting on the lung tissues to open up. In ARDS, because each and every alveoli is in a different phase of inflammation, they might experience a different strain altogether. The baby lung, which is near normal lung at that time, if we apply higher PEEP to them, higher pressures, they may undergo repeated atelectrotrauma, barotrauma, leading to more inflammation, more surge response. So that's why keeping the driving pressures at a minimum kind of reduces the inflammation and improves the oxygenation. So why are these concepts necessary? So what happens is, in this instance, a healthy lung, during anesthesia with FRC of 2000, we apply a tidal volume of 500, the strain would just be 25%. But in a same patient with an ARDS whose FRC has gone down very drastically to just 500, it would produce a strain of 100%, which is fourfold more than this lung would be able to accommodate. That's why the target is to prevent repeated barotrauma to the patients, limiting the driving pressures. So how do we interpret the driving pressures? It is basically the ratio between the tidal volume and the compliance of the respiratory system. Therefore, it kind of, what we are doing in ARDS is basically it is to the aerated lung volume that we are trying to accommodate the given tidal volume that we are accommodating into an aerated lung volume, and therefore it produces the strain that is there over that part of the lung. So why driving pressures were necessary is, I mean, why limiting the driving pressures became necessary is that over the years, after the tidal volumes were limited, it alone was not limiting the mortality in patients with ARDS. So what the randomized trials showed that an increase in driving pressures of 7 centimeters, 7 centimeter of water was associated with increased mortality, even if the two major things that were still being limited, the plateau pressures and the tidal volumes were still in accepted ranges, yet the mortality was high. So that's why limiting the pressures are very important. Now the current this thing is that to be limit it at targeted at about 14 to 18. If we are crossing 18, then the chances of barotrauma, more lung injuries are there. Therefore, we try to adjust the ventilator setting to get it back to the lower ones. The basic idea right now is that we assume that the airway pressure and the chest wall pressure are the same for a given patient. But in a few instances, as I will be showing in later, that they tend to differ. That's why another entity which we are now trying to correlate along with the driving pressures are the transpulmonary pressures. They are the transpulmonary pressures is the pressure between the airway opening and the pleural surface. So basically, it kind of tries to find out the pressure needed to overcome the airway, the chest wall compliance. It is measured using the esophageal manometry. The balloon is basically kept in the lower end of the esophagus, and its position is confirmed by general chest compressions. So when we see on the ventilator, we measure the airway pressures using the inspiratory pause. Simultaneously, using the esophageal manometer, we can measure the chest wall pressures. So as we can see over here, that before a pneumoperitoneum for a laparoscopy, the pressure seems to be fairly okay. The Peep plateaus and the Peep are about 6 centimeters of driving pressures over here, with pressures being esophageal pressures being just at 3 centimeters. But moment there was an abdominal insufflation, the esophageal pressure started to go up. That is expected because moment there is a pneumoperitoneum, the pressures are reflected into the esophagus. So the esophageal pressures have gone up. But what we start looking is that if this pressure start translating onto the lung in a very different manner than we expect, it is not going just by 3. Here the delta pressures have delta P, the driving pressures have gone up by 7. So even though the esophageal pressures have just gone by 3, the driving pressures have been going up by 7. So over a period, we have now realized that what affects the driving pressures after a while is definitely the chest wall compliance, the abdominal pressures. So when do these driving pressures and transpulmonary pressures begin to diverge? They tend to diverge with abdominal insufflation, intra-abdominal hypertension, like in pancreatitis, obesity, ascites, gross ascites, body position, especially when it is in Trendelenburg's position, thoracic trauma, when there is a lot of soft tissue edema causing restriction of the chest wall expansion, massive pleural effusions. So how do we adjust our mechanical ventilations and thereby give a protective ventilation at the same time? So the idea is that we set up with the basic tenets that we limit the tidal volume to 6 to 9 ml per kg body weight. We keep monitoring the driving pressures. If the driving pressures are increasing from the baseline or they are crossing about from 14 to 18 centimeters of water, in the patients who have a high risk conditions such as morbid obesity or abdominal hypertension, we see the plateau pressures are going up or not beyond 30 or not, because if it is going up beyond 30, that means the lungs are becoming more and more stiffer. If none of these things are met, then we can optimize the PEEP, recruit more lung, reduce the tidal volume even further. But if any of these conditions are there, then probably monitoring of the esophageal pressures would be helpful in sort of finding out whether the primary problem is in the lung or is it in the chest wall, and therefore monitoring the transpulmonary pressure over here would be helpful. So I hope in this short time I've been able to give some idea about the driving pressures. It is still an emerging concept. A lot needs to be understood, because one of the basic this thing is that we are assuming that our alveolar pressures are equal to our airway pressures at the end of inspiration, though it might not be the case. Like I've said, that the abdominal pressures might still be transmitted to the lung, but it is not always the case that it is never always given. The whole pressure is not transmitted to the lung. Some amount is definitely taken up by the elastic properties of the lung. So understanding this thing may take a little while, but probably help us going forward. I would like to again thank everybody to give me this opportunity. Thank you.
That was a very nice presentation, Dr. Jinay. Now I invite Dr. Justin to introduce the next speaker and go ahead with the next session.
Good evening, sir. It's my great pleasure to introduce Dr. Shiv Kumar, whom I know for the last 7 or 8 years, and I've had the pleasure of working with him. And over the last few years, he's been around the town, as in so he's training in PGI, Bangalore, and Manipal, and St. John's, and now in NH. So he's had an extensive experience in extremely busy and well-staffed units. And given his number of degrees, we do know that he's been well trained and has been pretty capable. And as one of my close friend, Dr. Ajit Kumar, used to say, he's an awake and aware doctor. So that's what it is. And I hope Dr. Shiv Kumar will keep the COPD patients awake and not asleep. And let's see how he does. Over to you, Shiv Kumar.
Yeah. Thanks a lot, sir. Thanks for the introduction. So I'll be talking about ventilation strategy in COPD patients. So as I'll be going through the slides, my topic, I'll be covering my topic over the following headings. So I'll be covering the importance of burden of COPD, the pathophysiology of COPD, that is important to know when we ventilate a patient with COPD, the basic ventilatory settings that we are going to use when we are ventilating a patient with COPD. So auto PEEP, how do we diagnose and manage auto PEEP, and how to troubleshoot a patient who is on a ventilator with a COPD. So the burden of COPD is quite high in Indian setting. The prevalence is around 4%. So if you take any ICU, be it medical or surgical, you will always come across a COPD patient who's on invasive ventilation. So knowledge of ventilation in a COPD patient is quite important. So, and as the number of people who smoke is increasing, the COPD burden may increase in the coming years. So we need to know about the concepts. Going to the pathophysiology of COPD. So basically, there is an increased airway resistance, and due to irreversible expiratory flow limitation, and there is destruction of the alveolar attachments of the small airways. And there is some component of mucosal swellings and or inflammation of the bronchus during an acute exacerbation, which causes flow limitation and increases the resistance in COPD exacerbation. So there is a decrease in elastic recoil, and all this leads to, and also there's component of VQ mismatch. So these patients, COPD patients, when they have an acute exacerbation, they are hypoxemic, they are hypercarbic, and because of which they've gone to the ventilator, and we need to know how to ventilate them. So the basic pathology is there is the dynamic hyperinflation due to auto peak or intrinsic peak, which causes an increased work of breathing in the COPD patients. So as you can see here, there is destruction of the alveolar walls, so which causes dynamic collapse of the alveoli, causing air retention or dynamic hyperinflammation, leading to auto PEEP, which increases the work of breathing and which causes trouble when we put a patient on the ventilator. So these COPD patients are ventilating at a higher FRC compared to a normal patient whose FRC is low. As you can see over here, COPD patients have a very high FRC, so that the lungs are operating at a condition of low compliance. So volumes are high. So we need to know that pathophysiology as well. Also, in these patients, because of barrel chest or emphysematous lungs, the diaphragm is pushed downwards, and the diaphragm is operating at unfavorable part of the length tension curve. The diaphragm is not fully functional compared to a normal patient as well. So coming to auto PEEP, that we need to know, it's also called auto PEEP or intrinsic PEEP, is nothing but positive end expiratory pressure in the alveoli at the end of expiration. So the basic the concept is there is dynamic hyperinflation that occurs with expiratory flow limitation is the basic cause in these COPD patients. Dynamic hyperinflation is the process. It is the process, but not always all auto PEEP is caused by dynamic hyperinflation. There may be a patient on ARDS also can have auto PEEP, but in COPD it's mainly the dynamic hyperinflation that leads to auto PEEP. Main causes patients with COPD exacerbation, they may have a high respiratory rate, they may have bronchospasm. Sometimes we may have put a small size ET tube. All contributes to increased resistance, which may add on to the auto PEEP. So the main effects, the important effects are there is an increase of work of breathing in these patients, and when there is an auto PEEP, there is an increase in alveolar pressures that can cause hypotension in these patients. Coming to management of COPD patients, there are two parts. There is medical management that includes your antibiotics, bronchodilators, steroids, but I'm not going to go into medical management. I'm going to concentrate on the invasive ventilatory management of these patients. So ventilation in COPD, the first choice whenever you receive a patient of COPD coming with an acute infective exacerbation is always a non-invasive ventilation. Non-invasive ventilation, there is enough evidence to show that NIV or non-invasive ventilation, there is reduced mortality. There is improved outcomes with the use of NIV in these patients. But sometimes even with NIV, the patient may fail an NIV, where a patient may have a worsening of respiratory acidosis. The work of breathing will start to increase. Hemodynamics will change. Patient may become hypotensive, or patient may become drowsy, where we need to intubate the patient and start on invasive ventilation. So main goals of invasive ventilation in these patients will be, the main goals will be to reduce the work of breathing. Even in NIV, patient is having increased work of breathing. The main goal is to reduce the work of breathing and optimize the pH and not the PCO2. So we are mainly looking at normalizing the pH in these patients and not the PaCO2. Auto PEEP, if there is auto PEEP, how to manage them. And in the last, troubleshooting. If you've intubated a COPD patient and there is alarms going on in the ventilator, how to troubleshoot them. These are the four goals that I'm going to deal with the next few slides. So the indications will be the patient is very tachypneic, dyspnea, respiratory rate of more than 35. Even an NIV patient is not holding on, very tachypneic. Worsening respiratory acidosis, when the pH is dropping, CO2s are increasing, pH is 7.25 and below. There is, because of CO2 retention, patient is becoming drowsy and where he's not able to maintain the airway, where you require an intubation. Hemodynamic compromise, maybe because of the auto PEEP or some other cause, patient is requiring vasopressors, high dose, then that time maybe we'll have to institute invasive ventilation. So patient is severely hypoxemic, PaO2 is less than 40 and PaCO2 is more than 60 with an impaired pH. All these will be the indications for invasive ventilation in these patients. So the next question is, we've planned to intubate the patient and we have put on the ventilator, which mode to use. So there is no consensus or evidence to say that one mode is better than the other. So always volume control is better in ventilating a COPD patient, because as you can see here, the volume control, there is a constant flow compared to a pressure control mode. And in volume control mode, the minute volume or your tidal volume is constant over different pressures. That is the advantage in COPD patient, whereas in a pressure control, you have set a pressure limit and there is a very tidal volume delivery. And also looking at the scalars and loops, you can diagnose conditions in COPD in terms like barotrauma or there is an increased plateau pressure. So that is the advantage, but you can use pressure control as well or a dual mode, but volume control is much easier to use. So the next thing is what is the initial ventilator setting? So you've tried to, if you intubated the patient, you need to set the initial ventilator setting. The first thing, FiO2, we need to target a saturation of 88 to 92%. A tidal volume, we don't want over destination in this COPD patients. Try to set a tidal volume of 6 to 8 ml per kg predicted body weight. Because of auto PEEP, there is there is dynamic hyperinflation. We need more expiratory time in these patients. So the respiratory rate of about 10 to 12 or much lower based on the next few ABGs, you can keep it. PEEP, after you intubate in initial few hours, you can keep a less PEEP or maybe 0 or 3, or better not to keep a higher PEEP in initial few time. Then IE ratio, because we need more expiration, we need a lot of time for expiration in these patients. So we try to keep a expiratory time. IE ratio, you can keep it 1:3 or 1:4. So in these patients, after you completed the initial ventilator settings, always check your plateau pressures. So if your plateau is less than 30, it's okay, because the value plateau pressure represents the alveolar pressure. Suppose the alveolar pressure is less than 30, the risk of barotrauma or polytrauma is less. So you can ventilate the patient with the same settings. Always in volume control, check your alarm limits. So in a volume control mode, there is a setting for alarm limits. So we need to set the alarm limits because you're in COPD, your peak pressures will be very high. So keep your alarm limits, the pressure limit maybe by 40 to 45. Have a look at that as well when you do the initial settings and check your plateau pressures. So the next question, you've done you've started ventilation of a COPD patient, but after some time you need to look at the ventilator graphics, and if there is auto PEEP, you need to diagnose auto PEEP. So how will you diagnose auto PEEP? Looking at the scalars and loops. So you look at the flow time scalar here. So as you can see here, there is the flow time scalar during expiration is not touching the baseline over here, if you can appreciate. Okay. And also if you see at the volume time scalar, the expiratory volume is not touching the baseline here. So there is some volume retention there because of dynamic hyperinflammation. So there is an auto PEEP. Some ventilators, in the Mackie ventilators, servo ventilators, there in the screen sometimes you see something called end expiratory flow, MVE. There some ventilators display this numbers. So if the end expiratory flow is on the higher side, like 5 or it's above 2 to 3, then that means there is some auto PEEP. And the maneuver to do and assess or measure auto PEEP is the expiratory hold. So if the patient should be sedated, well sedated and paralyzed. So you press a expiratory hold for at least 3 to 4 seconds, and look at the peak, PEEP. What is the PEEP on the ventilator? So you need to look at measure auto PEEP. The auto PEEP will be the difference between, so what you got it, what you after you pressed expiratory hold, the PEEP on the monitor and the PEEP that you have set. Suppose you have set a PEEP of 5, so auto PEEP will be 6 minus 5, it will be 1. So that's how you measure auto PEEP in these patients. So once you've diagnosed an auto PEEP in a ventilator, a patient is having auto PEEP, you need to know how to manage it. So so you're going to increase the expiratory time. These patients with auto PEEP that have flow limitation, you increase the expiratory time, you reduce the respiratory rate. If the respiratory rate on the higher side, you try to come down on it. Reduce the tidal volume. If your tidal volume is on the higher side, you reduce it so that you have more. You reduce the chance of polytrauma as well. So if the ventilator demand is high, if the patient is very tachypneic, sedate the patient well. If required, you can use neuromuscular blockers as well. So if the patient has a large ET, if the you use a large endotracheal size tube, suppose you have intubated a patient and patient's endotracheal type is on the smaller side, maybe you can consider changing the tube, putting a large size tube, suction bronchodilators so that you have reduced bronchospasm. If the patient has auto PEEP, then you can set an external PEEP that is about 60 to the amount of external PEEP set, that should be around 70 to 80% of the intrinsic PEEP. So how external PEEP helps in a patient with auto PEEP is explained by something called a waterfall analogy. So if you consider alveoli as the alveolar pressure, that is the water is flowing from alveolar pressure side to the airway pressure side. So the pressure in the alveoli is higher during expiration. There is a critical pressure where through which the alveolar air should come out. Suppose so there is auto PEEP over here. So the external PEEP should always be less than the intrinsic PEEP. If you're keeping a PEEP higher than the critical pressure, then that's going to cause worsening of auto PEEP. So always set your auto PEEP at about 70 to 80% of your intrinsic PEEP. So once you have controlled your patient has a controlled mode, you ventilated the patient. Now patient has improved, your bronchospasm has reduced. You try to next thing is you want to wean the patient. So you want to put the patient on a weaning mode. So most common mode you use is Cpap with pressure support. There are newer modes like proportional assist or NAVA that can be used, but most commonly at the bedside, what we use is Cpap with pressure support mode. The setting that you're going to use is FiO2 is the same thing. You target a saturation of 88 to 92%. So pressure support mode, you look at the tidal volumes to keep a tidal volume of 6 to 8 ml per kg. Based on the tidal volume is higher, you can consider reducing your pressure support. And important thing is trigger. So always these patients, keep the trigger sensitive. That means you always use a flow trigger because there is going to be less asynchrony and comfortable for the patient. And keep the flow trigger of 0.5 to 1 liter per minute so that it's sensitive and this patient does not require much effort to trigger the ventilator. The PEEP, as I mentioned, 75 to 80% of intrinsic PEEP if there is auto PEEP. And in your spontaneous modes, there is something called expiratory time sensitivity. So you're going to set it at around 50%. I'm going to explain that in the next slide. And other setting that you do in a spontaneous mode, in Cpap mode, is the rise time or the P ramp that you're going to see. That you're going to set it at about 150 milliseconds. Normally, we set it for other patients about 300 milliseconds. So for a COPD patients, we want a rapid, we reduce it to about 150 milliseconds. So to explain what is expiratory trigger sensitivity when we set a ventilator of a COPD patient in a spontaneous mode. So here is a flow time scalar. So the patient is taking a breath here. This is inspiration, this is expiration. So this is your peak flows over here. So once the flow reduces to about 25% of the peak flow, the machine will there is cycling to expiration. So this is in any normal patient who is not a COPD. But in a COPD patient, we want the inspiratory time to be shorter. We want more time for the expiration. So what we are going to do, we are going to reduce this from 25%. We're going to increase this from 25% to 50%. So there is cycling at 50%. So you have more time for expiration. So that is how you're going to set the expiratory trigger sensitivity. So rise time, as I mentioned, so these patients will have a high flow requirement during when we put a patient on, suppose the patient is tachypneic. So we want a faster rise time. We want the flow to rise to the peak flow with a short period of time. So normally we set it at about 300 milliseconds. So in a COPD patient, we set it at about 150 milliseconds, and always have a look at the flow time scalar so that your rise time is appropriately set. So troubleshooting. So we have you have a patient on a COPD on a ventilator. So there are problems that you can face. So sometimes you have a patient who's having hypotension, worsening of increased requirement of vasopressors. Always look for an auto PEEP. If there's auto PEEP that is causing an increase in alveolar pressure, increase in interthoracic pressure, causing reduction in preload and causing hypotension. So if there is auto PEEP, maybe temporarily you can disconnect the ventilator and make the appropriate setting to reduce the auto PEEP. So sometimes when you have a low minute ventilation delivery alarm. So in such scenario, you can look for any increased secretions causing bronchospasm. If peak pressure may be high, always check your alarm limit. Suppose your pressure limit on a volume control is set low, your tidal volume may not be delivering appropriately. Maybe you can increase the pressure limit so that you have appropriate minute ventilation delivery. So increased peak pressures in COPD is common. So your peak pressure may be on higher side. So always, if the peak pressure is higher, so check the plateau pressures. If the plateau pressure is normal, then there is a resistance problem. So there may be a bronchospasm. Maybe you can use bronchodilators to elevate the bronchospasm. So your patient may have. So the next scenario is you have a high peak pressure. Then you check a plateau pressure. So plateau pressure is higher. It's more than 30. That means there is a compliance issue. Compliance problem is that there may be a pneumothorax. So based on a high peak, whenever the ventilator is showing a high peak pressures, always check your plateau pressures and decide whether it's a resistance issue or a compliance issue in such a patient. So always target a pH maybe more than 7.2 and don't try to aim for a normal PCO2. It may be very difficult. PCO2 may be high, but always try to normalize your pH and not your PCO2. With this, I try to conclude by I think knowledge of pathophysiology of COPD is very important when you ventilate a COPD patient. Dynamic hyperinflation and intrinsic PEEP, you should be able to recognize and manage at the bedside. So the main key concepts use a lower respiratory rate, tidal volume must be lower, increase the expiratory time, give more time for expiration, target the pH and not reduction of normalization of PaCO2. So when a spontaneous mode, always you check your settings of expiratory time sensitivity, your rise time trigger in winning modes. Thank you.
Thank you, Dr. Shivkumar. And we will take questions, and I think somebody has already posted some questions. We'll take questions at the end, as Dr. Kanchi had earlier clarified. So I now ask Dr. Ratan Gupta to introduce the next speaker, please. Yeah.
Dr. Somnath, if you can please introduce the next speaker. Dr. Somnath, are you there? We have Dr. Sridhar. He will be he's associate consultant at Department of Critical Care Medicine at Narayana Institute of Cardiac Sciences. A very enterprising thing. Basic training is in anesthesia and then critical care. He'll be talking to us regarding ARDS. Dr. Sridhar, if you can share your slides.
Is it visible, sir? My slide?
Yeah, it's visible. You can go ahead. Go ahead with the presentation.
Thank you, sir, for such a wonderful introduction. We'll be talking about ventilation strategy in ARDS. Before heading to the ARDS ventilator strategy, we'll talk about ARDS pathophysiology. It's an acute severe lung injury that is characterized by severe inflammatory cascades, hypoxemia, and it's an heterogeneous condition having a diffuse lung involvement. So in 2012, Berlin definition came in to define ARDS properly. It is recognized based on onset, imaging, and origin of edema, and it is stratified into mild, moderate, severe based on the PaO to FaO2 ratios. If the onset is within 1 week or non-clinical onset, or a new or a worsening of respiratory symptoms in a presenting condition, or imaging showing bilateral opacities, and origin of edema which is not completely explained by fluid overload or cardiac failure. And if the questions are said yes, then it is stratified into mild, moderate, severe based on the PaO2 by FaO2 less than 300, it is mild, and 100 to 200 is moderate. And if the PaO2 by FaO2 ratio is less than 100, is called as severe type of ARDS. The consequences of ARDS are immediate consequences are profound hypoxemia, decreased lung compliance, and increased intrapulmonary shunt and dead space. So in whenever we ventilate such type of patients, so we need to focus on preventing further lung injury, which is already damaged by inflammatory cascades. Here today I'll be talking about ventilatory management in these following headings. So we'll talk about lung protective ventilation, that is tidal volume and respiratory rate management, open lung ventilation with management of Peep, and manuals to improve the oxygenation in terms of prone ventilation, use of neuromuscular workers, IE ratio, and recruitment manuals. So this is just a pictorial representation of early management of ARDS. So as per the recent recommendations, we need to assess the patient at least once in 24 hours to know the ventilation is effective or not. If the patient meets the criteria for ARDS, and we manage with the ventilator support with the tidal volume 6 ml per kg of predicted body weight. And as the severity of ARDS increases, we would like to will titrate the tidal volume to 4 to 8 ml per kg of predicted body weight, and try to maintain the plateau pressure less than 30, and keep the PEEP at least 5 and above, and check for any hypercapnia. If there any acidosis is not there, and we can continue to ventilate. As the severity of ARDS increases, we can consider increasing high level of PEEP if it improves oxygenation. And if the PF ratio falls further down less than 150, then consider proning use of neuromuscular blockers. And if it is very severe areas, PF pressure less than 80, have a discussion about initiating an VV ECMO. That will come to later. So whenever we decide to ventilate the patient, and question comes which mode of ventilation to use. So there are no consensus about which mode to use. Whoever are better with whichever mode they are comfortable, they can use. And pressure or volume control mode. Historically, intensivists used to prefer the pressure control mode, because in pressure control mode, you can see the mean airway pressure is higher, and the time spent by the alveoli at the mean peak airway pressure is higher compared to volume control mode. And alarm limits are set. These limits are pressures, so there will be automatic reduction of any barotrauma. So, but there are no evidences to support pressure control is better than volume control or any other mode. APRV, airway pressure release ventilation, is a promising mode where it allows the patient to breathe and keep the mean airway pressure at the higher level. But again, it lacks evidence to prove that it is a better mode in case of initiating mode of ventilation. And high frequency oscillator ventilations, these oscillate and the Oscar trials have shown that they actually has increased mortality and no for benefits. So whenever we ventilate the patient, either you can use modes which are comfortable, volume control or pressure control mode. So in terms of management of lung protective ventilation, most cornerstone of management is tidal volume. So one would like to set a tidal volume around 4 to 8 ml per kg of predicted body weight. It should be as a first approach when you ventilate ARDS patients. So the formula for predicted body weight displayed here, and these values are derived from ARMA study which came in 2001, which is an landmark study which compared 6 ml versus 12 ml of predicted body weight. So it had showed improved survival with almost 30 to 40% reduction mortality. And when we ventilate patients with low tidal volume, so the chances of barotrauma are less, and we tend to maintain the pH in the normal limit. If the pH drops because of CO2 retention, because of low tidal volume, one should increase the respiratory rate. As per the ARDS protocol, one can go up to maximum of 35 respiratory rate. So once the tidal volume is set around 6 ml per kg of predicted body weight, then we should always constantly monitor plateau pressure. One should not exceed 30 centimeter of water, because numerous studies and landmark studies shows that keeping the plateau pressure less than 30 has a better survival rate. This is a loop showing plateau pressure. So plateau pressure is measured in the inspiratory pause is pressed and the flow is off. So the pressure drops from peak to the next nidar. It's called plateau pressure. So next is a driving pressure. As Dr. Jane already discussed about in detail about driving pressure. It's a difference between the plateau pressure and the peak. So it is a ratio between the tidal volume to the respiratory system compliance. So recent study says that keeping the driving pressure less than 16 to 18 centimeter of water has a higher survival chances and reduced barotrauma and survival. one should think that driving pressure can be high due to underlying lung pathology or because of high set P or high set tidal volumes. One has to titrate the tidal volume P accordingly to set the driving pressure less than 16 to 18 centimeter of water. So this is an image taken from an EGM article which is published in 2015. So one can see as in the first image, as a plateau pressure increased, driving pressure also kept increased when the Peep is not adjusted. So it resulted in increased mortality. Whereas in image B, we can see as the driving plateau pressure increased, they adjusted the Peep to keep the driving pressure in the limited range. So it resulted in no change in mortality. But if you can see, when they kept plateau pressure flat and adjusted the Peep accordingly to reduce the driving pressure, it significantly reduced the mortality. So available data do not allow us to make a recommendation to make any respiratory settings based on solely on a limitation of driving pressure. The lung safe study, which came recently, showed that no obvious superiority of monitoring and setting the respiratory settings over plateau pressure as a predictor of risk of mortality. So analysis of a series of mechanically ventilated ARDS patients presenting with acute carpal suggests that when the plateau pressure is kept sufficiently below, that is less than 27, the driving pressure acted as a predictor of acute carpal and of mortality. Next is a open lung ventilation concept, recruitment manners. First one is a positive end expiratory pressure. So this is one of the important manure which will be used in case of management of ARDS patients on ventilator. The Peep, the beneficial effects of these are it optimizes the alveolar recruitment and decreases the intrapulmonary and thus improving the arterial oxygenation. So it decreases the amount of lung tissue exposed to repeated alveolar opening and closing, thereby reducing the risk of ventilator-induced lung injury. So there are still controversies about level of Peep, whether to keep a higher Peep or a lower Peep. What makes an Peep as optimal is the setting should be in optimal when the oxygenation is maximized. There is minimal end expiratory atelectasis or maximal end expiratory recruitment, and there is a minimal end inspiratory or distension, whereby they're preventing the polytrauma or barotrauma. So IEP should be used in patients with moderate or severe ARDS, but not in patients with mild ARDS. This proven and shown by numerous studies like Express alveoli LOS trials. IPEEP settings should be showed improved survivals as per the meta-analysis done by VMC, which is published in 2018. The concern still remains that a dynamic adjustment of Peep to ensure the low plateau pressure aligning with an overall lung protective strategy is more important than the level of Peep itself. So how do we adjust the Peep when we ventilate the patients? So we can use an arbitrarily some high Peep value, which want to be having some beneficial effects in mild to moderate to severe ARDS, or the proven or scientifically proven method is adjusting the Peep based on Arsenet protocol FiO2 table. One can use lower Peep, higher FiO2 table, or high Peep, lower FiO2 table. This one is taken from ARMA trial, where they went Peep up to 24. In current time, we don't recommend going the Peep more than 15 or 16. Another method of adjusting the Peep is checking the lower inflection point in pressure volume loop can be used to determine the critical opening pressure of the alveoli, and the Peep is set 2 centimeter above the that point. Or one can use a maximal static compliance technique. When the Peep is set at optimal level, the static compliance will be maximal. Anything which is you are using the Peep above that level, it may not improve the compliance further. So when we talked about good parts about Peep, keeping a higher Peep has its own deleterious effects. Like it can cause increased inspiratory volume and hence causing a risk of polytrauma. It may cause hemodynamic worsening by decreasing the preload, and above all, there is an increase in right ventricular afterload and it cause acute carpulmonal also. So next is the strategy by checking the inspiratory or expiratory ratio, or making it as an inverse ratio ventilation. So how does it work? So here they tend to increase the inspiratory time compared to the expiratory time. Basically, it works by increasing the intrinsic peak, thereby improving the ventilation of lung units which have long-term constants. And it also causes alveolar recruitment by increasing the mean airway pressure. It may improve the oxygenation temporarily, but it doesn't have any mortality benefit. It is may be considered, but it is not recommended. Next strategy is prone ventilation. The prone ventilation is recommended in patients with moderate to severe ARDS when the PaO2 by FiO2 ratio less than 150. So how does it help the patient with the moderate severe ARDS? It markedly reduces the overinflated lung areas while promoting the alveolar recruitment, and it prevents the ventilator-induced lung injury by homogenizing the distribution of stress and strain within the lungs. The transplantable pressure along with along the ventral to dorsal axis is more homogeneously distributed in the prone position than in the supine position. So in these type, it improves the ventilation and prevents further worsening of ventilator associated lung injury. So it is considered should be used in patients with ARDS with moderate to severe ARDS. And as per the ProSava trial, there they did sessions of at least 16 consecutive hours at a stretch for at least 4 to 5 sessions. The recent 2017 ATS guidelines recommends keeping the patient in the prone ventilation for at least 12 hours as a minimum. So prone position requires expertise, and for managing should be well equipped with proning because it comes with its side effects and the complications. So the contraindications for prone ventilations are very few, maybe countable. So like raised cerebral edema, or intracranial hypertension, or fractures of spine, unstable severe hemodynamic instability, or unstable spine, femur, pelvic fractures, or open abdomen. These are the few contraindications for proning. So coming to the use of neuromuscular blockers, they help in preventing the reducing the lung injury by reducing the patient ventilator dysynchrony and strong spontaneous respiratory efforts. The accuracy trial showed that there is a significant improvement in 90 days mortality and increased ventilator free days. The recent trial came, the ROSE trial, at followed up the patient at 3, 6, and 12 months. It did not show any endpoint improvement in terms of mortality. There is a systematic review and meta-analysis of 5 major randomized control trials showed that there is a reduced, if you use neuromuscular blockers within 48 hours of ventilation, it showed that there is a reduced risk of barotrauma and improved oxygenation after 48 hours without any worsening of ICU acquired weakness. Then comes to the recruitment manuals. The recruitment manuals helps in increasing the area pressure for a short period of time, and with aim to expand collapsed alveoli by allowing the better gas exchange. It can be done in a stepwise increasing the airway pressure or intermittent size. Other 2 techniques. Sorry. These manuals help to enhance the lung compliance and improve gas exchange by reducing intrapulmonary shunt. But there are no mortality benefits. Sorry. The ATS guidelines has given a conditional recommendation for use of recruitment manuals in moderate to severe ARDS management. So coming to the incidence of any side effects, complications of mechanical ventilation of ARDS patients, most commonly we see ventilator-associated lung injury. Incidence is not known because it is very high. It may not be recorded at all. And other complications like ventilator-associated pneumonias, right? Ventricular dysfunction or acute carpulmonary, pleural effusions, barotrauma, pneumothorax, systemic inflammatory response, prolonged sedation and immobilization, and fibropulmonary response to lung parenchyma. So these are the take-home messages and ATS and the ESICM society guidelines in case of when you ventilate the patients for ARDS. So there is a strong recommendation for ventilation patients with a low tidal volume and keeping the plateau pressure less than 30 and keeping the patient in the prone ventilation for more than at least 12 hours in a day and avoiding the high frequency oscillatory ventilations and use of prone ventilation. So these are my references. Thank you.
Very nice presentation, Sridhar. I invite Dr. Sudesh to introduce the next speaker, Dr. Karthiraj. Dr. Karthiraj, please come up with your presentation. You can share your presentation. Dr. Sudesh.
Can you see the slide?
Slides are visible, Dr.
Yes. So Dr. Kathiraj is a consultant in critical medicine in Narayana Health City, and today he's going to talk about weaning from mechanical ventilation. We've currently heard from previous speakers about both restrictive as well as the illnesses that that complicate compliance. But once the patient is better from those pathologies, how we're going to wean from ventilator, which is hopefully going to give us some direction about some new understanding of how we undertake weaning. Please go ahead, Dr. Kathiraj.
Thank you, Dr. Justin. So good evening, everyone. So my topic is weaning from ventilation. As we all know, discontinuation from ventilation is a great milestone, especially for patients who have been in ICU for longer time. Generally, we use the term weaning, but ideally what we should use liberation, because it's just generally a one-step process, and just we cut off on the ventilator if the patient is good enough and we move to the next step. So when you look into the liberation, what you should know is that it's ideally have 3 steps. First is readiness testing, next is weaning, and then extubation. So when you go to readiness testing, what do you mean by readiness testing? It indicates that you see and evaluate whether the patient is good enough to go to next step. Okay. So it involves evaluating the patients and assessing whether whatever has been reason, like what is the reason for the patient initiation mechanical is reasonably addressed. Okay. And it includes looking at clinical criteria and physiological tests. So when you into what you look ideally, so in this first, what you should see is the reason for initiation of mechanical ventilation is resolved. Improvement in the cause of respiratory failure has been improved very well. So reasons of initiation of mechanical ventilation can be not due to non-respiratory causes also. For example, the patient is a post-op patient who must have prolonged surgery, massive fluid shift, just want to keep the patient stable. We might have just electively ventilated overnight. So hypothermia has improved, hemodynamic stability is better. And if the respiratory cause, if there is a good improvement in the respiratory failure, for example, if it's just hypoxia or ARDS, make sure the oxygenation is better. When will we feel that patient is good enough? Generally, if the FiO2 requirement is 50 or lesser with a Peep of 10 or less, and then the PF ratios is more than 150, with adequate oxygenation. And then if there is improvement of pH, the acidosis can be due to respiratory or non-respiratory reason. If it's due to non-respiratory reason like sepsis or renal failure, ketoacidosis, but these acidosis can be improved significantly and good enough that pH is more than 7.2. And the next is hemodynamic instability. What do you mean by hemodynamic stability? It doesn't mean that patient should not be on vasopressor, but just that if there is a decreasing trend in the need for vasopressor, if previously it was a 2 or 3 vasopressor requirement, and if it's just a single vasopressor or maybe a non-real single strength less than 10 ml, and we feel that in the next few hours it may be reducing, then that is good enough to plan that, okay, patient is ready enough to go to textless. And then yes, patient should take adequate, good, spontaneous breath. Okay, so how will you prepare and what are the recommendations from the chest and ATS related to making the patient good enough for get ready enough? So first one is every day we should have protocols to minimize sedation. So daily when you go and see the patient, see whether this patient can be stop sedation and see whether patient can be moved to the next step. And next is every hospital should have possible ventilation regulation protocol. So liberation protocol means, okay, every day go and see whether we can reduce the FiO2 for the patient, reduce the peak for the patient, and we can stop the sedation and even stop the paralytic patient also, and see whether we can move towards the next step. And then protocolized rehabilitation should be there in all hospitals. So when you see what you mean by protocolized rehabilitation is, rehabilitation is, it's not that patient should start rehabilitation after the patient is extubated. So even if the patient is on a ventilator, we can make few measures like passive physiotherapy or make the patient high sitting and motivate the patient so that when the patient is extubated, transitioning to remove from ventilator and allowing the patient spontaneously will be easier without any discomfort. So these are the suggestions or recommendations given by ATS in 2017. And then when you feel that patient is ready enough and feel that patient good enough to go to next step, we do what we call as weaning. So what is weaning? Weaning is decreasing the degree of the respiratory support and allowing the patient to breathe on by her or him more. So in this, weaning can be categorized into 3 things. With simple wean. Simple wean is the patient passes the first weaning trial successfully. If the patient passes the first weaning trial successfully, patient is said to be simple to wean. Difficult to wean, when a patient is said to be difficult to wean, if they fail their first weaning attempt and require up to 3 spontaneous breathing trials or up to 7 days to pass an SBT. So patient should be difficult to wean. Prolonged weaning, if the patient is requiring more than 3 attempts, they fail 3 attempts, they require more than 3 SBTs or more than 7 days to successfully pass weaning, the patient is said to have prolonged weaning. So in weaning, what are the methods tried? Previously, what we are doing is the pressure port ventilation with SAME pressure port, where we didn't have assist control. There only control mode ventilation was there. So we changed the SAME pressure port, gradually reduce the respiratory rate of support. But now what we do is the spontaneous breathing trial. I'll talk about those details in later. But now we have a newer weaning methods in which I think previously they have told about the proportional assist mode, and ASV, all those things help in weaning in a computer-driven automated mode. Computer-driven automated can be used for having prolonged weaning, not ideally needed for simple to wean, difficult to wean patients, but for spontaneous breathing trial is what we all use. So what do you mean by spontaneous breathing trial? So in this spontaneous breathing trial, what you do is we just reduce the ventilatory support or change the patient to spontaneous breathing mode or a TPs and allow the patient to breathe for 30 minutes to 2 hours. So this is only just TPs, where in which you just disconnect from the ventilator, put in a TPs at 1 day and you give an oxygen and then see how the patient is breathing. So it can be either by TPs or Cpap or PSP. So TPs, as I said, like this, patient is not connected to the ventilator, just allow the patient to breathe by itself. In Cpap, what you do is you connect the patient when you just continue the connection, but change the mode to Cpap mode, but you set only the Peep. There is no pressure support, there is no pressure augmentation, only the Peep. Peak can be 5 or 6 or 8, whatever it is. So in this, what happens is that there is only continuous positive pressure either during inspiration or expiration. So when the patient exhales, the Peep, the airway pressure is still what you set as Peak 5 or 6. When the patient inhales, there is an increased flow, but still the airway pressure at the end of airway or alveoli is kept still at 60. The increased flow is given to compensate for the negative pressure that is generated. There is no augmentation of the pressure during inspiration. The next is pressure port ventilation. In pressure port ventilation, there is an augmentation of inspiration. So you said 2 levels. One is Peep, which can be 5, 6 or whatever it is, and pressure support, which is generally kept at 5 to 8. So in this, when the patient starts inspiring, there is an additional pressure generated. So at the end of inspiration, the airway pressure, alveolar pressure will be Peep plus the pressure port. So if you keep a Peep of 5 and pressure port of 5, the end of inspiration, the pressure will be 10, but at the end of expiration, pressure will be 5. So which is better in this? So when you look into it, ATS and chest guidelines say that for hospitalized patients who are ventilated for more than 24 hours, we suggest inspiratory pressure augmentation rather than TPs or Cpap. So what they suggest is do a pressure port ventilation, and it's a conditional recommendation with moderate quality of evidence. So why they say this? Because what they say is that when you put a patient on either TPs or Cpap, there may be increased effort that may be needed for few patients, not for all patients, and few patients need an additional support. So those who fail CPAP and TPs doesn't mean that they will not be comfortably extubated. There are few proportion of patients who can be successfully extubated when you do this method. So what they do is stress on reducing the duration of mechanical ventilation and maximizing the possibility of extubation success. The PSV mode helps in extubating even more additional group of patients who may not be successful in CPAP or TPs. So they suggest doing pressure port augmentation, PSV ventilation, for patients who have been ventilated for more than 24 hours. Okay. So now, when you do a spontaneous breathing trial, we have to see whether the patient is successfully passed spontaneous breathing trial or not. So for this, we look into various clinical parameters. Yes, we look at the respiratory system, we look at the cardiovascular system, and then along the respiratory, look at the gas section, we'll be looking at the ABG, and then other neurological systems also. So in this, what you look at first is, yes, respiratory rate, more than 35 should not be there, but some patients who have been ARDS they have baseline rate of 25 to 30. Sometimes we allow higher rate of up to 38 also. And then you look whether there is a presence of respiratory distress or thoracoabdominal paradox. When these things are there, we feel that patient has failed SBT and put the patient back on control mode, and then we test next day. And then looking into hemodynamics, if the heart rate is more than 140 or 20% increase from the baseline, or there can be bradycardia, it can be due to respiratory compromise or hypoxia, or hemodynamics, look into it, increasing blood pressure, again more than 21 baseline, or SBP more than 180, or fall in BP from less than 90. So, and then the oxygenation, we can look at the ABG, but otherwise clinically you can see if you put the patient on pressure port ventilation with a FiO2 of 40% and saturation is 92 to 94, after 1 hour and you see that the FiO2 requirement is increasing to 50%, saturation only 90, it indirectly indicates that, okay, patient is going for hypoxia and distress. Just stop this, maybe you can put him again, rest the patient, try next day. And then yes, otherwise increase in PaCO2 or decrease in pH when you do an ABG. And neurologically, if the patient's sensorium worsens, patient becomes distressed, obtunded and drowsy, or the clinical diaphoretic, then we feel that patient is not good enough, failed the XPT, we can go back to the control mode. The other thing which generally look into is the RSBI, Rapid Shallow Breathing Index, which is calculated by calculating the respiratory rate by tidal volume. In tidal volume, what you should note, you calculate tidal volume in liters here. That's what you should. So for example, if you put a patient on a spontaneous breathing trial and the patient is doing a respiratory rate of 30, and then the tidal volume generated is varying around 300 ml. So you put 30 divided by 0.3. So it's not by 300, it's 0.3 because it's in liters. When you calculate it, so it's 30 by 0.3, it's 300 by 3, which is 100. So RSB is less than 105. So this patient more likely will have successful extubation when extubated. The lesser the RSB value, more optimal, more good that patient will be having successful extubation. Okay, these are the only thing that needs to be looked into. Those are the main things that you should be looked into. If any one of these fail, then maybe you can defer extubation. But there are other parameters that has been looked into. For example, tidal volume of 5 kg or minute ventilation of less than 10 liters per minute, respirator of 35, and P0 and what is occlusion pressure, which you look into, and then maximal inspiratory effort. What is maximal inspiratory pressure? You allow the patient to breathe and see how maximum the negative pressure can be generated. It indicates the adequacy of the respiratory muscle and diaphragm. If it's less than 20, it is good, and then the patient has good effort. But what they say is these measures are good, but patients who are not fit getting these things have been successfully extubated. So these respiratory parameters, which we have been looking into it before, has not been strongly, strictly followed. So if it is not, that doesn't mean that we cannot extubate this patient, but we have to look into the previous suggestions which have been told. Okay, but now we all know that diaphragm in ultrasound has become very much common in use in anesthesia and in ICU. So of late we started looking into the diaphragmatic function by ultrasound. So two things we generally look into. One is the diaphragmatic excursion, that is the diaphragmatic contraction movement during inspiration. Other is a diaphragmatic contraction. Diaphragmatic excursion, look how low the diaphragm excurs during inspiration. And generally, if it is more than 20 mm, the possibility of successful extubation is more likely. But if it is less than 10 mm, extubation failure will happen in most of these patients. So they have a cutoff of 20 and less than 10 to 20, it can be borderline. The next is diaphragmatic contraction. You look at the thickening of the diaphragm. That means that when the patient inspires, the muscle contracts, so muscle thickens. So you have to look at the 7 to 8 intercostal space just below the pleura and see how much contraction happens in the diaphragm. If the contraction is increased by 30% or more, then patient can be extubated successfully. These parameters are coming new, so we have not been include any guidelines as hard guidelines, strong guidelines to be followed. But these are the additional things which we can look into when we plan to extubate the patient. Okay, so now we feel that okay, readiness testing has been done. You did a spontaneous breathing trial, and patient has been successfully passed the extubation, spontaneous breathing trial. Can we go ahead with extubating the patient? Next final step is looking at the safety of extubation. In this, we generally look at two things. One is assess for airway protection, whether the patient will be able, because there is a tube that is there that has been protecting the patient from upper airway related issues. Okay, but when we take the tube out, will there be issues at the upper airway which might cause concerns when we take the tube out? What are the two things? Whether the patient will be able to protect the airway. How can we know whether the patient is able to? One is the patient is having a good GCS. Patient will be conscious, alert enough, and see whether is having good swallow and whether is having good cough. So in cough, generally look at the peak expiratory flow. Peak expiratory more than 60 liters per minute. Then we say that patients have a good cough. And yes, when we extubate, patient will be able to clear the secretions, cough secretion, and able to extubate them. And next is whether the patient is at risk for post-extubation stridor. Our concern for post-extubation stridor is about issues with at the subglottal below the vocal cords, because when you look here, there is a small space between the trachea and the endotracheal tube that is being inflated with the cuff here, but sometimes there is a chance of edema in this area. But since the tube is there, it just expanded it, and then so that we don't feel that's a thing. But when you take the tube out, if the edema is concerning, then yes, it can cause post-extubation stridor. Okay, who are the patients who are at risk for it? Who had laryngeal edema, like injury, who had stenosis, stenosis secretions and large. These are patients for whom are at risk for things, and we can look at for cuff whether the patient will have stridor or not by looking at the cuff leak. So what is cuff leak and what is the recommendations related to it? So as per the ATS recommendations, they say you should do a cuff leak test for mechanically ventilated patients who do the extubation criteria, who are high risk for post-extubation stridor. So who are the patients who are high risk for post-extubation stridor? Who had traumatic intubation, who are on a ventilator for more than 6 days, who have a large ET tube, in female sex also they say the high risk patient, and who has been re-intubated after unplanned extubation. So unplanned extubation indicates the patient was extubated without the cuff deflated. So there might have been possibility of upper airway injury. So for these patients, we have to do a cuff leak test. Okay. Now, if the patient has been otherwise good, but failed the cuff leak test, but feel that patient, okay, less likely there is any way the patient will have upper airway obstruction, can we go with extubating the patient? Yes, the recommendation is yes, we can go with extubating the patient who have failed the cuff leak test. That means there is some edema is there around the tube, but otherwise good after extubation. But go ahead with giving a steroids. What this suggests is give steroids, methylprednisolone, 20 mg 12th hourly for 4 doses. First dose given 4 hours before extubation. So giving this dose, we can go ahead and extubate the patient who are otherwise fit enough, just fail the cuff leak test. Okay. So now post-extubation management. So what would you do for post? Generally, most of the patient, we can just go with conventional oxygen, high venturi mask, and then go and ventilate, then continue to oxygenate the patient. But there are few patients who may need an additional respiratory support in the term of NIV. So again, here the chest recommendation suggested we suggest the patient to extubate to NIV, which is strong recommendation with moderate quality of evidence for those patients who are at high risk for extubation failure. What are those patients? There are multiple studies looking at various categories of patients, but more important, all those categories, the group of patients has been included are patients who have hypercapnia. Yes, who have tight respiratory failures, we'll extubate to NIV. COPD patients, because they have issues related to their airways. So for those patients, even they may not have tight respiratory failure, go on with extubate NIV. Congestive heart failure who have reduced ejection fraction, NIV helps in improving the afterglow. These are 3 high-risk patients who you should extubate NIV. Yes, along with it, there are other patients like who have multiple comorbidities, who have been ventilated for longer time, who have been having type 1 respiratory failure and extubated. So these are the other additional high-risk patients who might be successfully extubated when you extubate to an NIV. Okay, now these are recommendations that has been done. Yes, of late, yes, HFNC has been increasing in use, especially after COVID. We started using HFNC. Is there any strong suggestion? There are a lot of studies comparing HFNC with conventional oxygen therapy. What is conventional oxygen therapy? Oxygen therapy just with venturi mask. Okay. In that, yes, obviously HFNC fared well with almost every group of patients. So there could, but when studies comparing NIV with HFNC, few studies said that HFNC fares better, few studies said that NIV is better. There's no clear-cut conclusion and say that we have to give HFNC when compared to NIV for these patients. But as per the recommendation, there are they suggest high-risk patients. They ask us to give NIV. But yes, HFNC can be considered in few other group of patients. For example, many cardiothoracic patients, extubation to HFNC may be better, and patients who have major abdominal surgery where NIV may be relatively contraindication. So we can, for these patients, yes, we can try using HFNC. And yes, also ARDS patient who might feel that NIV, they may not be cooperative NIV, and then we can try extubating them to HFNC. But India, the concern is the cost, but that's a different thing which needs to be looked into. But as per the suggestions and recommendations, as such, there's no strong recommendations to suggest HFNC over NIV in this setting. That is in a scenario of post-extubation management. So with this, almost I'm coming to the end of the talk. So liberation is generally a one-day process for most of the patients, except for prolonged patients. That involves first is readiness testing, which includes whether we can go to the next step, and next is the weaning trial, which is generally done by PSV, that is pressure port augmentation. If they are successful, do a cuff leak test before extubation. If they pass the cuff leak test, we can extubate NIV for high-risk patient, I suggested before. But if they fail, otherwise good enough, we can give them steroids and extubate them with steroid cover. So with this, I just end my talk. Thanks to the organizers for allowing me to talk this. Thank you.
Thank you, Doctor. Thank you very much for a eloquent talk. May I request Dr. Muralidhar and Dr. Ratan to moderate the session.
Yes.
All
the 4 speakers have done very well. Yes. All the 4 speakers have done very well. Thank you. And also, I think we have enough time for discussion. And to set the ball rolling, I will just ask Shashidhara, is there any difference in extrapulmonary and pulmonary ARDS in terms of ventilation?
No, sir. Ventilatory strategy for extrapulmonary and pulmonary same only. So we have to keep the plateau pressure less than 30. Ventilate them as low as the low tidal volume of 6, better than 6 ml per liter body weight, and Peep for moderate to severe, and consider higher Peep. Minimum Peep is 30.
Thank you for that response. Ratan, please take over and conduct the discussion. There are a few questions. If you want to go through that, please
Yeah,
feel
I
free.
think we have tried answering a few of the questions which are posted. I think one of the questions was how do you calculate the driving pressure during pressure control mode of ventilation and PRVC mode as well. Sometimes we call it as pressure controlled ventilation with volume guaranteed ventilation. So I think Dr. Jinay, if you can just discuss that.
Calculating driving pressures during pressure control, it is the pressure limit minus the Peep would give us the driving pressures in a pressure controlled ventilation. In a PRVC mode, putting an inspiratory pause during the inspiration for at least 3 seconds so that the alveolar pressures are matched up to the airway pressures would give us the plateau pressures, and from there we can subtract the Peep to get the driving pressures. So inspiratory pause is the key for PRVC mode.
And I think the second part of the question is what is the relevance of driving pressure in anesthesia patients with normal lungs?
In normal other surgery, routine surgeries, I don't think so it would matter much, but especially in abdominal surgeries where we are inflation, abdominal insufflation is happening, robotic surgeries, laparoscopic surgeries, or surgeries with pancreas where the abdominal pressures will be transmitted to the lung, and though the lung tissue is normal, but those pressures are going to be related to the airways. So at that in situations probably driving pressures less than 18 might prevent more barotrauma, more injury to the lung, help them get out from the ventilator at a earlier in the post-op period.
Yeah, that's a very valid point. Murali sir, you want to add to that anything, sir?
Frankly, no, because especially in cardiac surgery, the surgeons like to have the tidal volume low. That also helps the surgical access to the part where they're operating. So it benefits both ways. So 6 to 8 ml per kg will be more than enough.
Yeah, I think they also want to protect the lima pedicle.
And usually we do not use any anesthesia. Yeah.
Yeah. Okay. Dr. Shukmar, so you have answered that. Can you just discuss how do you set the rise time for control modes?
Yes, sir. Rise time. So rise time is mainly in echoing. 1 minute. So rise time is mainly set in spontaneous mode, in a fully controlled mode. So in a volume control mode, we don't set a rise time. Only when we have a pressure support mode with when we try to wean a patient, then we can set a rise time. Rise time can also be set on a non-invasive ventilation when we put a BiPAP machine. So then you can in such not in a fully controlled mode.
Dr. Somnath, I have please go ahead.
I might just slightly contradict Dr. Shivkumar. What I just, you use a rise time in all modes of ventilation, whether it's volume control. In volume control, you don't, but quite often you today use a good marriage of pressure and volume control, which is called PRVC, or in pressure control ventilation. In a control mode, you would set a rise time, and it's normally set at about 100 to 150 milliseconds. So that's the standard, and you can slow it down further if your peak pressures are overshooting your flat pressure significantly. So it's used both in controlled and in spontaneous, but mostly in pressure modes, which is pressure controlled or PRVC. And I just like to probably add one more thing. One of the things that's not been very well discussed in this group is the answer to the question is, do you use volume control or pressure control? I've stopped using either. I use only PRVC presently. That I find is a great marriage between pressure control and volume control. You get the benefits of pressure control, where is the initial high flow, and you get better flow distribution, earlier flow distribution, and therefore your peak pressures are limited. So the disadvantages of volume control, where you have the possibility of increasing plateau pressures and P peaks, and the problems that you have with pressure control, where sometimes your volume will change as your compliance changes, is managed by using PRVC. And I've hardly used pressure control or volume control in the last 10 to 12 or maybe even 15 years. It's been PRVC right through.
Yeah, I second that.
And I think this is a great marriage between the divide between across the Pacific, the Americans and the British and the Australians. We almost universally use PRVC.
Yeah.
I don't know, Justin, what's your?
Yeah,
It's,
just
it sounds too good to be true, isn't it? Not. So, like, obviously, like, I've used volume control SIMB combination when I was away from India, both in UK, Australia, and Canada. But when I came back to India, I started using predominantly pressure control because that's what the local system is used to. So I didn't want to change that, and I adapted to it. So that's probably what our main was at this point of time. So the titration for me is still volume control with the fallback, and maybe using PCV with variable ventilator availability. If not all places will have modern ventilators, so for the so-called decelerating ramp for the restrictive lung diseases. So that's probably my basic differentiation, and probably like earlier discussed, I think some of these things are managed to be put together, not because physiologically, but because it reduces the amount of monitoring a doctor has to do. And I guess that's probably one of the things that it like when you set parameters that you want, and I guess the safety is assured. Whereas when I'm looking at a lot more crisper numbers, and I probably prefer to use my own cocktail, which is like a VCV that we've been using for nearly 25 years now. So for most of the alveolar disease and maybe PCV for restrictive diseases. That's my take. Like I said, and I think there has been an increase in the use of PRVC across the board. I guess we've had quite an extensive set of talks today, from initiation to liberation, and both in so-called restrictive diseases as well as alveolar pathologies. So at the end of the day, most of that, I think the take-home message for people is probably that we are trying to reduce what a ventilator does to the body. And that seems to be quite high. And the more we undertake and more care we take, the better we are. And so essentially, the Willy sometimes has more mortality than original pathology in some of the situations. And hence, extracorporeal strategies seem to be in the rise because they seem to negate the effect of ventilator. And we started using more and more adjuvants to mechanical ventilation, like using sedation or prone ventilation or ECMO or early extubation to NIV or high flow, and all these things. And I'm sure in all these things, the mode of ventilator and some of the minor things probably are not featuring too much, as long as some basic things are addressed, like you give low volume and reasonably good PEEP, and keep looking at the patient again and again. And I think as simple as that, I think that's probably is my take. And I wanted to ask Dr. Shivkumar if he can talk us about what are the strategies he would undertake for work of breathing of a patient who is on ventilator, not necessarily on control ventilation.
So maybe this patient is on control ventilation, maybe this patient is on not sedated, maybe you can consider sedating the patient well. So if a lot of the patient having fever, maybe we can control the fever, pyrexia, reduce the temperature, so the work of breathing reduces. So those are two things. If the patient is on, maybe we're thinking to wean the patient, then respiratory rate is high. Those things can be considered to reduce the work of breathing. That's it.
Yeah.
Analgesia sedation.
Yeah. The other thing, simple thing, like sometimes if the patient doesn't have a Ryle's tube, if he's gulped in a lot of air and there is a gastric distension, maybe just aspirating the Ryle's tube might help. That we see sometimes in post-surgical patients, where sometimes we are not placed a Ryle's tube, thinking that we'll be extubating early. The other thing which I found interesting is Dr. Karthiraj's talk. The fourth limb, apart from checking the readiness and weaning and then extubation, sometimes extubation is not the end. You have to support the patient depending on the cardiac condition and the pulmonary artery pressures, the LV function. We all know about the heart-lung interaction, and continued support post-extubation with the non-invasive ventilation has become pretty standard, especially post-surgical patient, major surgery, like cardiac surgery, we use it quite regularly, extubate to NIV, and then gradually wean off. And sometimes when there's a poor LV, we continue with nocturnal Cpap for an extended period of duration, or for the entire duration of the hospital stay sometimes. And the other thing which we do is the HFNC usage. As you mentioned, the compliance is much better when compared to NIV. And if it is the work of breathing is all right, and the patient is basically having problems with the PO tools, HFNC works wonderful.
Yes,
we are able to tide over for a couple of days, then I think patients get better.
Yes, I think as you said in the even
sorry, Karthi, please continue. Please continue.
no, so I think as Sir said, I think even the recommendations also, who was having like a poor LV, they suggest to extubate to NIV. That's one of the recommendations in the 2000. But as Sir said, maybe you can continue for longer time till the patient is moved out of the ICU, so that it will help in improving the overall respiratory function, improving the cardiac output.
Yeah.
Yes, sir.
For Justin and
I have a couple of questions.
Sure, sir.
I have a couple of questions, but before that, I would like to ask Suresh what they do in Bangalore. Do they use pressure controlled or volume controlled, or you marry them and use that PRVC? What do you do then in Bangalore? In your unit, what is the most popular mode of ventilation? You will have to unmute. You will have to unmute. Suresh, you have to unmute yourself.
Sir, in Mangalore, it's more of PRVC, sir, as Sir said. Yeah, we use more PRVC, sir, in our ICU.
That's great. That's a happy marriage. That's what.
Yes, yes. And we are very comfortable with that, sir. PRVC.
Super. That's great. That's great. My question to any of the panelists is that when we use VV ECMO, we accept a saturation of 88 to 92%. But when you're ventilating, you get worried when the saturation comes down below 95 or 93. What is the reason for this? Is there any reason? Anyone can.
Can I take that question?
Do you agree with me? First of all, do you agree with
me? I completely agree with you. I think this is one of the biggest problems in intensive care. I don't get worried when my saturation is more than 95. I actually get angry when my saturation is more than 95. My patient saturation is more than 95.
Right.
That means that the weaning is not being done adequately. That means you're not turning the FiO2 down adequately. You're not. So my philosophy, which has been really cemented during the COVID ventilation, is aim for saturation around 88 to 90, maybe 92%. 90 to 92 is a great sweet spot. Yes, it does decrease the margin of error if something goes wrong, but that you have to compensate with vigilance. I insist saturations are definitely less than 95%. Constantly people are tweaking things down. That means people are going and seeing the patient on a regular basis. You empower the nurses to be able to do this. And educating the nurses is very important. And this is something, Dr. Mulidhar, I completely learned from how you, during ECMO, you don't target saturations more than 90.
Right.
So I think that's very, very, very nice of you to bring that up. Permissive hypoxia has not been discussed extensively. I think it's not been given the credit that it deserves. And I suppose even the permissive hypercapnia. And if you, again, probably marry permissive hypoxia and permissive hypercapnia, the risk of ventilator-induced lung injury is likely to come down. Again, that's my way of thinking. Do I have adequate evidence for that? I think it's intuitive. It may be difficult to have evidence that is required, but that's the way I believe ventilation should be.
Now the tendency is to move away from having high saturations even in acute MI. And if you look at the ACLS guidelines for post-cardiac arrest care, they are recommending only 92 to 98. Anything is fine. From 92 to 98% is fine. So any other responses for this?
Sir, I would like to try to answer that.
Yes.
So when you are on ventilator, I think once your saturation is below 90, as Dr. Somnath mentioned, the margin is very narrow. Any further drop in the saturation, PO2's saturation will drastically come down. So that might be one of the serious concerns. Whereas when patient is on VAV ECMO, you're pretty sure that you will be able to maintain the saturations, even if it is targeted at 88. It's a little more controlled environment when compared to a patient on ventilator. Maybe that is the reason why people are happy to keep VAV 88 saturation, whereas on ventilator, they're targeting it slightly on the higher side. Somnath has got a valid point, but I think that might be the reason why people are okay with VAV 88 and.
You're talking about VV ECMO.
ECMO, VV ECMO.
They accept 88,
VV ECMO.
88 to 90, 92, that's fine.
But what
Somnath said, don't target the saturation, but you have to look at the oxygen delivery, how much is being delivered. Yes, Justin.
So I think obviously both have been done in ARDS group of patients, essentially at this point of time. And then, so I think 8 years ago, I think there was, or 10 years ago, there was a paper that came out, or proof of concept paper, where they looked at the PO2s, the lowest PO2s, and they seem to have 3 to 6 month neuropsychiatric evaluation of these ARDS survivors to be lower. And so there is that association of lowish PaO2s, not saturations, the PaO2s. So that's there is some evidence suggests that there is low PaO2 targets are associated with bad. And the flip side of the discussion is that if you have severe hypoxemia and you need to do permissive hypoxemia, and then if you have a severe hypercapnia and need to do permissive hypercapnia, and you have both, then essentially your measures or adjuvant measures that you use will be increased, including extracorporeal, and should not be about trying to tolerate it. So essentially that's telling me that he needs more lung rest than trying to somehow reduce the energy that we are driving into it, into the lungs. I mean, that's my point of view. And I guess in India, I think ECMO is still an evolving science, and then the survival is still below 30%.
Okay, let me put this question this way. If the saturation is 90%, will you extubate the patient?
On ECMO?
No. In general, somebody you're ventilating, and saturation 90%, and will you extubate, or you want to bring it to 95 and then extubate?
90 tells me that he's probably not quite there yet.
Right.
Yeah.
I'll just qualify.
I
definitely would not extubate. I definitely would not extubate, but what I'm trying to say is you saturations more than 95%, does mean you're using more oxygen, you're probably hyperventilating the patient. So I do agree with Justin, but most often what will happen is, when you do aggressive ventilation, you're also looking at increasing villi. And therefore, that might be something that will also contribute towards pushing
you're not
patient
aggressively
towards
ventilating.
extracorporeal therapy.
No, you're not aggressively ventilating. You're just put the patient on spontaneous breathing trial and the saturation is 90. So my question is, will you go ahead and extubate because
I'd go by the PF ratio. I'd go by the PF ratio, and definitely if PF ratios have a good margin above 300, yes, I'd probably hesitate to ventilate, extubate the patient with a saturation of 90%. It would just increase the risk of, extubation failure. But during mechanical ventilation in a patient, my targets are definitely less than 95.
Karthiraj, you want to say something on this?
Yes, sir. Regarding, we look at the oxygenation and then status. We are looking to overall how the patient is trending. If the patient is improving and you feel that oxygenation getting improved, lung is recovering, and the saturation is 90 to 92, and then otherwise patient is fitting into the parameters, comfortably pass the pressure port ventilation, pressure pause spontaneous breathing trial without any desaturation, and otherwise good enough. 90 to 92, if it is there, yes, we can go on with extubation with this patient. But for weaning, I think that should not be a problem. 90 92 is good enough to start at weaning. But if there are other parameters, overall looks good, and you feel the patient is going to recover and improve over a period of time, yes, we can go ahead with, if all these things got into. But if still not completely improved, the lung condition not fully recovered, and 90 is still there, we are concerned. If your recommend is 50 or more, then I think we should still go, give some more time and wait for the patient to recover even more, and then plan for an extubation. So looking into overall picture, how the trend is, how much, what you expect in next 24 to 48 hours, and then plan it.
I think the other thing is the age factor. In case someone is elderly, his saturation may never be coming very high. So
yes, sir. Yeah,
we have to accept a little lower.
Yeah, exactly. That's correct.
Yeah, that's right. Actually, we also have to look what was the previous saturation. And if his saturation 96 on 40% and on breathing trial, it has come down to 90. It
Yes,
could
sir.
mean that he might be wetting his lungs, and what is the quality of breathing he's doing, whether he's doing his comfortably breathing or he's getting distress, is there any sweating, is there any tachycardia? All those clinical signs might be considered before we think of pulling out the tube.
Okay.
And you said about cuff leak test, is there not a danger of risk of aspiration when you do that?
Correct. I think I just want to talk about how to do a cuff leak test, but they say that yes, you have to, because now in ICU, generally we use a patient with subglottic suction. So before we have to do a cuff leak test, you make sure that you clear the oral airway, and generally we have subglottic suction. So we clear the secretions and even put a ET suction to the ET tube, so that we have almost reasonably cleared whatever collection is there, and you have to deflate the cuff. So this is how we have to ideally do a cuff leak test before, and then you see whether the patient has passed the cuff leak test. Just want to talk in detail because of time. I thought just tell them the test alone so that
thank you for the clarification.
Yes, sir.
Thank you so much. Ratan and Justin, if there are any points to be discussed, please.
There is one question.
We will have another.
There is one question where they mentioned. Can you discuss about the effects of long-term mechanical ventilation? I think diaphragmatic fatigue is one thing which is quite common. Not only with long-term ventilation, even short-term ventilation, we see that. And of course, nutrition, Dr. Jinay has discussed that bit on the chat box. How many of us do we use ultrasound for assessing the diaphragm in the patients who have been ventilated for a while? Justin?
No, I am not necessarily the guy with the probe. So
Somnath, I think he uses a lot of ultrasound.
yes.
We do use ultrasound, but not not for assessing the diaphragm, not that much. If we are suspecting patients who's rheumatic palsy, then yes, but otherwise not really on the 30% increase in thickness. We'll try it.
Yeah, Shivkumar is a big fan of ultrasound. So what is your experience, Shivkumar?
Not on all the patients. Only when there is a clinical suspicion, only when you have a long-term patient where we have difficulty to wean, and we want to make sure that diaphragm is okay, then definitely I look at the excursion, how much that diaphragm is moving. Then I would, or else not on all the patients.
In cardiac surgery, we have something specific. Patients who undergo Lima harvestation because of the proximity of the phrenic nerve with the internal mammary artery proximally. Quite a few times we have left-sided diaphragmatic weakness, especially when you do a Lima harvestation. It can happen even on the right side, but left-sided diaphragmatic palsy, once the patient is extubated, when the X-rays are done, if you are seeing a diaphragm going high, I think that is a strong suspicion. And in the adult population, unilateral diaphragmatic palsy generally is well tolerated, unlike the pediatric patient. And the only thing different we do is have extended period of NIV in these patients or Cpap during the hospital stay. Most of the patients get away.
So may I ask Dr. Shivkumar, obviously we have discussed mechanical ventilation for all these patients. We initiate for COPD patients, the box standard is that you have to give them NIV at least, unless they're in the extremities, you do give them at least 2 hours to prove their worth, whether that could limit their ventilator requirement. So we do use a lot of scores to decide on these people other than just the subjective assessment. Like when these patients on ventilator come to getting better, would you use the same scores when they're about to wean rather than just looking at the numbers again? Would you use the score?
We don't look at the score. We just look at when we want to wean a COPD patient, we see how he tolerates a SBD trial. We're not looking at numbers. We look at his how like primary pathology, whether if it's come with an infective exacerbation or some other cause, whether that has been corrected. But I would definitely not look only at numbers. So see how the patient is doing on a SBD trial. The rate is okay. His CO2s are okay. Not only any there are scores to suggest NIV failures, but that I'm not sure that has been validated in a COPD patient who we want to extubate or wean.
Yeah. So, I guess the medicine is a law of probabilities. I think we continue to improve our probabilities by adding and subtracting one or the other, said, using scores or other things. So, for Dr. Kathiraj, obviously spoke about weaning, and so I would want him to see if he can tell me what would his bedside assessment would be for a clinical scenario of difficult weaning. A 60-year-old male with community-acquired pneumonia, diabetes, hypertension in the background, now has been on ventilator for 5 days. He's better. He's required SBT 2 or 3 times in the last few days, and so this would quantify him to be a difficult weaning. And I want you to tell me what you would look at the bedside for this patient, Dr. Kathiraj. Yeah.
Okay, fine. Yeah, thanks for the question. So when you look at it, yes, we go with a spontaneous breathing drill, which is obviously a pressure port augmentation, especially for patients who is kind of difficult to wean. So obviously I'll start, see the FiO2 and Peep recommends pre going for pressure port, and ideally we want it to be 50% lesser, Peep of 5 to 6, not more than that. So continue the same FiO2 with a Peep of 5 to 6, and then give a pressure port of PSV of 6 to 8, maybe start at 8. And see how the patient ventilates. The parameters which we look into, yes, obviously, look at the ventilator, look at for the tidal volume delivered, respiratory rate, and then see how he's, look at the flow and how his exhalation is happening. At the same time, look at the monitors, look at for the heart rate, blood pressure, saturation, all these clinical parameters looked into, and then yes, the patient, or yes, first, look at whether the patient is having distress or how the patient is feeling comfortable, or is feeling diaphoretic or fatigue. So all these clinical parameters that should be looked into. And then if there is any issues happening, then just see whether sometimes there can be some reversible causes, like patient has some acute bronchospasm that can be happening. And if you feel that occulted the patient, just a bronchospasm, that is the reason. Just try to give a nebulization and see whether that, because just looking at this parameter, we can't just go back to control mode again, put the patient back. For few patients who's been on longer ventilation, you don't want to prolong the duration of ventilation. See whether we can do, there can be simple secretions also just blocking in. Try to see, put in a suction, clear it. If there is a if there is a bronchospasm, try to give nebulization and see. Look at these clinical parameters and see whether patients be able to tolerate. For these, at least you should give at least 2 hours, because this is a difficult to wean patient. 30 minutes of SBT might not be good enough, because for a post-surgical patient, that's okay. Here you see for 2 hours, and yes, you have to look at the ABGs also, see whether, though we can see whether there's no drop in saturation. Look at the ABGs, whether PCO2 is getting raised or not. Look at the pH and look at these parameters. And then if you feel the patient is good enough, and then if you have to still 40, Peep of 6 and saturation 92 or more, then we can just try to go extubating the patient. Yes, to and bridging in IV. That's the way we can go ahead and then see if everything is good and good.
So, I mean, I wanted to see if, what else that you use objectively in these patients. Let's, for example, think that like the patient's oxygenation is not bad, like, you know, the ABGs are fairly good, but he has already needed 2 or 3. And most of the time it is not practical for us to be standing by the bedside for 30 minutes and look at the patient. We just put the patients on ventilator, can press support or tell somebody to do it, and we walk away. And then at some point, somebody will report to you, say, get a gas at 40 minutes or 30 minutes. And then it usually happens at 1.5 hours later. And then they come back with the report. with the report. And so like, when you go back at that time, or when you're walking back, you realize that the patient's still on pressure support. So essentially, unfortunately, the so-called extended SBT is more a reality rather than what we actually do. But you know, ideally, sort of. So let's, for example, this patient has an RSBT of, let's say, 95. And how would that change your decision making? His PaO2s are better. Respiratory rate is about 32, which is still under. Not much change in terms of like, you know, respiratory or hemodynamic variation is low. There is one, but it is not high enough for you to be worried. So would you still, what else would you use other than these things to objectively improve your probabilities of success?
And good. So now, obviously, now here comes what we call the bedside, what we use, the ultrasound. So we can start using the ultrasound and see, as I said before, as we discussed, the diaphragmatic excursion and the diaphragm thickness. See whether the excursion is good enough. More than 20 is good. If you have the diaphragmatic excursion of more than 20 that's really good. And then look at the thickness fraction after inspiration. If it's increased more than 30%. And even along with it, you can look whether the patient is having B-lines or any other issues that can be looked into. There can be minimal B-lines which can present in most of the patients, especially in this group of patients. We see whether it is increasing, if the need, that can directly we look at the increase in oxygen requirement also. Look at these things, especially we can use the ultrasound, look at the diaphragmatic contraction, and then you see, and then if you feel that patient is fairly good enough and improving otherwise, then we can, then as I said, go for the cuff leak test because they have been on prolonged ventilation. So cuff leak test, and then we can plan extubation.
That's good. So I guess I take. Go ahead, Dr. Kanchi.
The simplest thing is to ask the patient whether he's comfortable breathing or not. If he says he's dyspneic, we have
he failed the test immediately.
Probably both considering LV
it's
dysfunction
not
as well.
But it does help.
Yes, sure. We'll clinically see, and then look for the clinical. Then yes, you should ask the patient whether they're feeling comfortable or feeling disturbed.
So, like you said,
Justin, can I
go ahead, sir. Sorry, go ahead, sir.
Sorry, Justin. You know, obviously, I'm just going to try to help Karthiraj here. The way I would look at it is, you have a patient who is borderline for extubation. You're not very sure. Give him a day, or give him 6 hours, give him 12 hours. And if he's not, you know, deciding in terms of his physiology, that is your rapid shallow breathing index and a SBT, or then you then have to have an appetite for risk. At the bed end, do you think this guy is going to cope? Do you think he's got, mainly a oxygenation failure or a oxygenation and ventilatory failure? And then cuff leadness is okay. He's going to be able to, is his cough good enough? You can take a trial of extubation onto either NIV or HFNC, continuously monitor him and then wean him. If he passes that test, he's weaned. If he doesn't, he gets re-intubated.
Yes, sir.
Right?
Yeah.
And then if he gets re-intubated, think about the tracheostomy.
But the re-intubation is a quality index, you see. We cannot, it tells me how good I am. It tells me how good I am. But at the end of the day, I want to improve my probabilities. The whole discussion is about how I'm going to verbalize the probabilities of predicting somebody's success. That's all I wanted to know. So we're going to use ultrasound. I have a feeling it is a mixture of a volume and a pressure index, both the lung volume as well as the and maybe an indirect measure of how much the patient could generate a negative pressure. So I mean, they are the two things that seems to be not a very clear marker of one or the other. On a ventilator you could see both in separate ways, like PO1 or negative inspiratory force, or those are the indices that you tend to see for what would be the main criteria that would determine a difficult weaning is the fatigue. So most of the patients who get extubated or about to be extubated, the families ask me how many days I want to be in hospital. I said at least 3 days. They have 3 hurdles to go. First hour, first evening, and third evening. First hour, glottic edema. First evening, fatigue. And third evidence is a secondary sepsis. I mean, this is box standard understanding of the thing. So for me, it is always going to be that fatigue, which is what I'm poor at predicting, which evidence proves that we are pretty poor at predicting. I think we have less than 50% chance of predicting somebody's success or failure. And most of the time it's a luck of draw. Unless we make a constructive effort by using all the pressure and other indices. And like Somnath said, you have to have the appetite for it, which means that you have to learn the art. At the end of the day, it only comes when you spend a little bit of time and get that art, and maybe assessing the patient in a more objective way whenever we are seeing these things and improving one's probabilities. So that's a difficult weaning. Probably is much worse group to predict than simple weaning or prolonged weaning in my clinical practice. And that's what I just wanted to discuss the scenario. It's not about getting a right answer. It's about
how we move forward.
One more thing, sir, we would like to consider is an LV dysfunction, which we tend to overlook very commonly as a reason for weaning failure. As in most patients, diabetic hypertensive do tend to have at least grade 1, grade 2 diastolic failure. And diuresis just helps them very, very drastically. So probably
that is true. That is
one
true.
thing probably
Actually, the clinical scenario I mentioned about saturation coming down from 95 to 90 could be a manifestation of diastolic dysfunction. I think there is an indication for us to conclude the session, but there is one last question.
Dr. Muralidhar, I'll ask for 1 minute extension.
Can volume support ventilation to be used for weaning?
So so these are so when you look at volume support ventilation, yes, you can do it, but see, volume support are now advanced mode where you try to adjust the volume support, give so that whatever volume support the patient needs. These are newer one computer generated modes, but when you look into straight and false pressure support ventilation, simple and easy. If the patient passes it, we can go to the next support, next way of next step, whether we can extubate the patient or not. But can we do volume support? Yes, if you have it, if the options available, you can go ahead going ahead with volume support ventilation for weaning. It's not that you shouldn't do it, but since PSV is easier and it's this volume support ventilation may not be available in every ventilator and is easily used, so we just suggest that pressure support ventilation is the best way to go with weaning.
Yeah, it's more easy understandable.
The
Yes,
other
that's right.
advantage with the volume support is it's available on Siemens Servo 300. And there's an automatic transition between weaning mode to control mode in case there's a increased respiratory rate or the patient doesn't trigger. Automatically, the ventilator will change from volume support to PRVC. So the patient doesn't have any, the safety margin improves there. That is one advantage with volume support.
Thank you. Thank you, Ratan. I think we should conclude this session. I would like
Dr.
to.
Muralidhar, can I
Yes,
take
yes,
a
sir.
minute?
Yeah,
I'll just take a minute. Just a few comments. How my practice has changed with regards whether it's severe COPD or a difficult to ventilate patient. We are CT scanning our patients more frequently, and quite often we will find findings that will change how we manage the patient. That's one thing that we have learned over the last few years. Whether, depending on where the consolidation is, how you position the patient. Suppose you have patients with large bullae, your appetite for higher peeps, all of that, and the risk of pneumothoraces. So this is something that's we are increasingly doing. I completely agree with Jinay when he said LV failure. So fluid control in a difficult to ventilate patient is, I suppose, something that's equally important.
Yeah.
The other thing that I would probably, to Karthiraj is we've stopped doing spontaneous breathing trials. The reason we've stopped doing spontaneous breathing trials the way you said, which is to connect them to a T-piece and give them oxygen, is that one, you can't, once on the SPT, you have no measure of volume, right? So you can't do your rapid shallow breathing index. You can measure the respiratory rate, but you can't do a volume. So what we've moved on to is to do you put the patient from pressure support ventilation or Cpap mode, and put them on switch on the automatic tube compensation. So when automatic tube compensation is done, it compensates for the resistance of whether it's a tracheostomy tube or an endotracheal tube. And then you put your pressure support down to 0, and you can compensate, your ATC will compensate 80% or 100%. The advantage that we find that way is your volumes are monitored. You can do an extended SBT, like Justin was talking about. You're able to have the other parameter, which is your volumes are monitored. So this is something we've stopped taking the patient off the ventilator onto a T-piece. We just do the automatic tube compensation.
Yes, sir. I think that's what it's suggested. So in spontaneous breathing trial, there are 3 techniques that can be followed. But PSP is what we ideally have to do. That has been strongly recommended. Yes, and if you have ATC in your ventilator, that's really good, so that it just looks into overcomes the resistance offered because of the tubes, and then it helps in getting successful SBT more likely if we do ATC for this patient.
Yes, so that's the other thing, and the other one other thing is a lot of people still talk about ventilatory settings of Is to E ratio. I find that a bit disconcerting because I prefer to use inspiratory time as a fixed constant, because whatever we do, we are moving towards less sedated patients. And if you use an IE ratio that is constant, then as the patient starts waking up, even on a controlled mode of ventilation, their respiratory rates will go up, and effectively their inspiratory times will come down. So your pressures may go up. So it's just something that we move to inspiratory time, keep the inspiratory time around 0.8 to 1 second. I don't know. Maybe it's something that's a fetish of mine, but that's what we've been doing. I just get worried with IE ratios. IE ratio is a product of your inspiratory time.
Agree.
I think we need to also over this. So I would like to thank all the participants, Ratan, Justin, Somnath, Sudesh, for having been with us, and Jinai, Shiv Kumar, Sridhar, and Karthiraj for that excellent deliberations. Dr. Jayashri or Baljit is available to say vote of thanks. Baljit?
Well, I'm here. If Dr.
Yeah, oh, great.
Well, good evening, friends. It's been a wonderful evening. It was the discussion following the presentation, excellent presentations, of course, and what followed thereafter was icing on the cake. Very engrossing and very interesting discussion with a lot of wisdom that each one has put out of experience, not from books. So that's where the beauty of the discussion lies, and the moderators have done a wonderful job. From one question to another, from one opinion to another, and from one speaker to another. It was just wonderful. I mean, it was spellbinding, I must say that. Thank you so much, all the speakers, and of course, all the moderators. And on behalf of Indian College of Anesthesiologists, it's very pleasant duty to thank you all and look forward to having you again sometime on this platform. Thank you so much for a wonderful program. Thank you so much and good night.
Thank you, Dr. Jayashree Sood, and
Thank
thank you,
you.
Dr. Baljit.
Thank you so
Thank
much. Thank you.
Thank you.
Bye-bye. Good night. Thank you.
We'll see you sometime. Thank you so much. And you're invited for a virtual dinner now.
Virtual
Thank
dinner,
you.
yes.
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 Good night. Also, we are closing here. Good night.